ago, the medical community thought that our hormones declined because we age. The more recent research is making it clearer and clearer that perhaps we age because our hormones decline.
Hi, everyone, and welcome to Evolving Ageless. This is the Enlightened Women's Antidote to Aging. I'm Michelle Dreilich, I'm your host, and I am on a mission to change the way we as women age. And each week, I'm joined by experts, clinicians in their field, researchers, and they're sharing with us the latest and greatest information about their field. And so this week, I'm super excited. I've got Dr. Ryan Shelton, who's joining us today. Dr. Shelton is an integrative medicine physician, and he's right now practicing in Champaign, Illinois. His area of expertise is actually quite vast. He's worked in cancer treatments, pain management, in primary care and patient and family care. And he does quite a bit of work in the area of bioidentical hormones. So I thought it would be a great conversation to have because I hear so often from our community, are hormones right? What kind of hormones? I thought hormones give you cancer and things like that. So I wanted to ask Dr. Shelton if we could dive a little bit deeper into the whole picture of specifically for women, because we know we're in this evolving pursuit of living ageless. So welcome today, Dr. Shelton. It's so good to have you here.
Absolutely. It's a pleasure to be here. Thanks, Michelle, for having me today.
You bet. So tell us a little bit about how you came to find this whole area of hormone therapy, uh, bioidenticals versus regular hormones, where it all begins.
So for me personally and professionally, it began about 10 years ago. I was employed by a large compounding pharmacy based out of San Diego that specialized in compounding and developing bioidentical hormone replacement therapies for both males and females. And I was one of the primary researchers, really digging into the research, not only about how it affected one patient to the next, but looking at larger studies on how bioidentical hormone replacement affect certain risk factors for cardiovascular disease, for osteoporosis, and certain types of cancer. And so one of my initial tasks was to really make sure that the hormones that were being prescribed from doctors throughout the country were not only effective in their state, but also safe, at the dosages prescribed. And I've worked with hundreds and hundreds of women, identifying that their levels of hormones were decreasing and attempting to come up with the best formulas that we could to make sure that they were both effective and safe.
That's great. And so when you mentioned when a woman's hormones are decreasing, and so there's so much information out there, it would be so helpful if you could take a few minutes and just kind of describe what symptoms or side effects or just things that you should be on the lookout for that could be indicative of someone's hormones declining with age.
Absolutely. So I'd like to start with 2 points. Even as recently as 10 or 15 years ago, the medical community thought that our hormones declined because we age. And the more recent research is making it clearer and clearer that perhaps we age because our hormones decline. And so catching it early and addressing it early in those women who have deficiencies, very, very important. And the endocrine system or the hormonal system is, I like to think of it as a symphony. And if one element of that orchestra or symphony is out of tune, you will not enjoy yourself. And it's similar when it comes to hormones. They all work together. So if we're talking about estrogen or progesterone, testosterone, yes, women produce testosterone, or cortisol, growth hormone, oxytocin. All of these hormones work together, and when one becomes imbalanced, the others try to catch up, and it's important to look at the entire endocrine system as we age so that we can understand what to best address and how to make the most effective clinical benefit. Now, for women going through the transition of menopause, I always like to point out that from a medical standpoint, menopause is actually defined as one day, one single day. So, medically defined, it is 1 year, 12 months after your last period. Anything after that is postmenopausal. Anything prior to that in a symptomatic patient clinically is defined as perimenopausal. So the average 1 day of menopause occurs in the US in most females between the ages of 50 and 51. 51.4, I think, is the average age. Although perimenopausal symptoms can begin 5 to 6 years prior to that. So we're looking at maybe early 40s, mid 40s, when some of these symptoms start to arise for many women. And if we're just focusing on the female hormones, say estrogen and progesterone, the one that tends to decline first is progesterone. And symptoms of progesterone deficiency can be anxiety, sleeplessness, irritability. They can be breast tenderness, bloating, weight gain. And so if you start to experience some of these symptoms in your early to mid 40s, that might be an indication that you're beginning the symptoms of the menopausal or perimenopausal transition. Estrogen deficiency are more of the classically known elements or symptoms of menopause. They include night sweats and hot flashes. That is more directly related to estrogen, and they do not occur typically, they do not occur as some of the initial symptoms of the perimenopausal transitions. Those symptoms tend to develop in the later 40s, early 50s, when estrogen levels begin to decline. And for me and my patients, it's all about a balance. Of course, it's a clinical presentation, so we have to understand where the patient, where the woman is during her transition, and 80% of the time, the diagnosis is based on clinical signs and symptoms. Of course, we use laboratory to back that up and to understand more precisely where those progesterone levels might be, where those estrogen levels might be, testosterone, growth hormone, cortisol, oxytocin, and DHEA, the entire endocrine or hormonal system. But progesterone deficiency symptoms tend to present well prior to estrogen deficiency symptoms.
That's interesting because if we go back to the statement that you said earlier, which was it's not so much that our hormones decline because we age, it's that we age because our hormones are declining. And so the signs that you're seeing in your clinical practice, I think this is probably maybe like a aha moment for certain women in the audience. It could be as soon as 42, 43 that you start to see these signs of this early progesterone deficiency. And you had mentioned things like anxiety, irritability,
Weight gain, water
weight gain,
retention,
bloating.
breast tenderness, changes in breast tissue.
And it's interesting because I think that if I look at a woman's life historically, if you're, the late 20s and 30s are children years, and then 40 is family and career. And, we don't pay as close attention to ourselves as women because we're busy taking care of everyone else. And these are subtle changes, maybe the sleeplessness we chalk off to, having kids or having a busy career, or or we're just getting older. But there are signs now that we can start to pay attention to. So this is fascinating. So you essentially start screening patients sooner when they start coming in with complaints like this in their 40s. Is that how you look at it?
That is accurate, and the research all shows that there's cultural variation on how women transition through hormonal changes in their 40s and 50s. And many cultures honor the transition of their 40s and their 50s and transitioning into their postmenopausal years. They designate that as a time of making changes in their life so that their roles may be different. Often women find that transition to be quite empowering, and they take on roles that they did not have the confidence perhaps of taking on earlier. They were distracted with childcare, they were distracted with other issues of being in their 20s and 30s, trying to make it through college, trying to be the best woman that they can. And this transition in the 40s and 50s represents a moment where I feel like many women can respect that transition and accept new roles and responsibilities in their life. And that shows transculturally, because some experiences of perimenopausal and menopausal symptoms are quite different in other cultures. If you look at women going through the transitional changes in Asian countries, in the continent of Africa, in certain European countries, their perception of that change is different than what most Americans expect and expect out of themselves. And that can be problematic in terms of exacerbating the symptoms of that transition. And so if we are able to respect and honor that transition through the mind-body relationship, the physical symptoms tend to be less severe than in cultures such as the United States, which look upon this transition as something negative.
Mhm. I love that. Right. I remember there was a poem, "When I am old, I will wear purple socks." Right? And it really speaks to this coming of age where a woman finds herself. And I can see that now. I mean, I turned 51 this year. And so there's just I can't describe it. I couldn't write it down. There's just an awakening that happens. And it can be a positive experience. And so let's talk now about questions I think that people usually have about the use of hormones. What's the difference between, I mean, the literature shows historically that hormone replacement therapy is dangerous, right? Causes cancer, causes heart disease. Tell us a little bit about the difference between those studies and what was used then and the kind of hormone therapy that you're talking about, which is quite different.
Sure. So some of the initial prescriptions for hormone replacement therapy were synthetically based. They were, for instance, for estrogens, they were equine estrogens. They were derived from horses, and the metabolites of those turned about 55% into estrone, which is E1. There are three basic forms of estrogen in the body: E1, estrone; E2, estradiol; and E3, estriol. About 55% or so of equine estrogens they're metabolized into estrone. And most perimenopausal, most menopausal, postmenopausal women are already producing plenty of estrone. They don't need any more of that. And the other 45% of equine estrogens, or those synthetic estrogens derived from equine or horses, are metabolized in the liver through pathways that potentially could increase risk for certain types of cancer: cancer of the breast, cancer of the uterus. And so it wasn't until about 15, 20 years ago where practitioners really began to prescribe bioidentical hormones, and the research was more engaged into bioidentical hormones to look at the differences between synthetic and bioidentical. So the bioidentical hormones, there's never been a single study that shows an increased risk for cardiovascular disease, for osteoporosis, and for other long-term postmenopausal conditions such as Alzheimer's that is related to bioidentical hormone replacement. There are those studies for synthetic hormones or equine-based hormones, but not for bioidentical. There's never been a single study that shows that. And depending on the route of transmission, if the hormones are taken orally versus if they're applied topically as a gel or a cream or a patch, the body metabolizes those hormones differently. So we do know that oral estrogen is metabolized into compounds that increase something called 16-hydroxyestradiol, which places women at an increased risk for breast cancer and uterine cancer, hormone-sensitive types of cancer. And transdermal application, or gels and creams or patches applied to the skin, is not primarily metabolized into that 16-hydroxy, rather the 2-hydroxyestradiol, which is protective or can be protective against those estrogen sensitive types of cancers in the breast or uterine tissue or ovaries. So not only is the dose important and the source is important, making sure that it's bioidentical, also what is important is how you apply it. So if it's transdermal versus oral bioidentical hormone replacement, the body metabolizes those hormones very differently. Another case in point is progesterone. So progesterone is one of the first hormones that becomes deficient in females. If we take an oral progesterone, bioidentical, if we take an oral progesterone, the liver metabolite, the first liver metabolite is allopregnanolone, which is actually quite calming for the brain. And so for women that are experiencing anxiety, irritability, sleeplessness, an oral dose of progesterone can be more effective specifically for those symptoms than a transdermal dose, which does not get that spike of the first pass through the liver, changing that progesterone into the metabolite allopregnanolone. And so, again, it all comes back to how a woman is presenting, what those symptoms are, what she wants to be, what symptoms she wants addressed today. And that may change 2 or 3 or 5 years down the road because hormone levels, of course, change.
So that is why it's so important, actually, to find a practitioner to work with on this, certainly because you can't get a prescription otherwise. But more importantly, you need someone that knows the right questions to ask and to know when it might be time to change maybe the dosages of things in alignment. And it's a very personalized experience. This is not a one size fits all experience where
No.
here's your pill, here's your prescription, have a nice day. This is something where you need to work together with your patient or with your practitioner to find the right balance. Yeah? Is that what you would think?
Absolutely. So not just for estrogen and progesterone, also for growth hormone and cortisol, DHEA, thyroid hormones. 80% of it is a clinical diagnosis. And that's why I became a doctor in the first place, to understand the clinical presentation, the medical history, the physical examination that takes place. Most of the diagnosis occurs through clinical diagnosis, and we can confirm that with laboratory results. But sometimes, especially in the initial transition of perimenopause in your early 40s, mid 40s, even late 40s, most of that diagnosis is coming through a practitioner that has experience identifying what those deficiencies, signs, and symptoms look like, confirming those with laboratory testing, and then treating those symptoms, treating those hormone imbalances in the most effective and safest way that we can.
hmm And you mentioned something earlier that I really want to touch on because I read an article recently that stated the exact same concept, which is the sooner this is addressed in a woman, the better the trajectory for all the positive benefits of hormone replacement therapy, right? So meaning that the longer we wait, if someone is presents into your office 15 years past menopause, right? Postmenopausal, there's only so much benefit they can expect to achieve from that versus starting sooner. Is how would you describe that?
That is absolutely correct. And so if we wait, in your example, if we wait 10 or 15 years postmenopausal, women will not reap the benefits of bioidentical hormone replacement versus if we initiate those treatments early on during the transition in the early, mid, late 40s, women will have not only symptomatic improvement as we prescribe the hormone replacement therapies, but long-term benefits improve as well for cardiovascular disease, osteoporosis, dementia, memory loss, Alzheimer's. So the sooner that we can identify those transitions and implement a treatment strategy, the better the woman is today and in the future for years to come.
That is great. And it makes me think that, if there's any piece of advice out there, it would be if you're talking to your practitioner and suggesting that maybe you're noticing a decline in hormones, or maybe you're starting to feel yourself kind of circle the drain, right? Maybe your menstrual cycles are spreading out and you're seeing these symptoms um, of menopause, and you speak to your practitioner and they suggest maybe you're fine, this is normal, just wait it out. um, you might want to have other conversations and maybe and seek additional guidance or a second opinion from another provider, because time is an important aspect, as we're learning from Dr. Shelton. So I would definitely encourage you to have a conversation. And it's not about, not every, it may not be for you, it may not be something that you want to pursue, but knowing that time matters, it's absolutely worth exploring the conversation if it's right for you. So along those lines, who is not a candidate for bioidentical hormone replacement therapy?
Well, that's case by case, as
Mhm.
medicine should be. It's always case by
Right.
case. If you have a personal history or a close familial history, a family member that's close to you, a mother, a sister, an aunt, that has had a hormone sensitive cancer of any kind, if it is in the breast tissue, uterine tissue, ovaries, then that really needs to be a deeper conversation between the doctor and the patient, and also the rest of the team. If there is an oncologist that the patient is working with, really understanding what type of cancer risk that the patient has and proceeding accordingly according to those risks. So history, personal history or familial history of cancer is something that really involves a more profound and deeper conversation between the practitioner and the provider. Now, as we know, many patients are on medications. In fact, polypharma is not uncommon, where they're on multiple medications, maybe for cholesterol as they age, maybe for blood pressure as they age, maybe for other health conditions, diabetes, or vision changes that occur, or any other pre-existing condition. Those, of course, need to be addressed case by case, because it's certainly possible that the medications that they're taking, important medications that they're taking for their processes, are, compared to any type of hormone replacement therapy, that would be instigated for symptoms, clinical symptoms of uh, hormone deficiency, so that we make sure that the patient is not just treated effectively, but as safely as possible. And I have many examples of patients where they are on medications, they have no or very little cancer risk, and those medications, working with their other provider that prescribed the medications, may need to be adjusted as we implement bioidentical hormone replacement therapy.
Interesting. That's really good to know. And so I also know that there is a correlation. And so it's worth, I think, stepping backward now and saying, the way we live our lifestyle can have a profound effect on the timing of this, decreasing progesterone, decreasing estrogen, and certainly the severity of the symptoms that are associated with it. So I know that you talk about the 5 pillars of health. If you could just touch on those really briefly, I think it would be super helpful to know that this exists and that it's relevant to the picture of hormones.
Sure. So I like to talk about a therapeutic ladder with my patients, and rungs on that ladder. The lower rungs are no less important than the higher rungs, but I begin on the lowest rung, which is diet, nutrition, and lifestyle. I look at what they're eating now, what they have been eating over the years. I look at their dietary sensitivities. I look at their macronutrient intake, their micronutrient intake, to determine if anything can be implemented to use food as medicine as we help them through the transition. Next, I look at exercise. I like to call it therapeutic movement because some people think exercise means going to the gym and doing cardio and weights, and it can mean that. But for some individuals, it's as simple as just moving and making sure that you're engaged in physical activity each and every day. So I look at diet, I look at nutrition, I look at exercise. The next rung up that ladder would be the detox mind-body relationship. So there's no doubt, and science is becoming clearer and clearer, that exposure to environmental toxins can disrupt our hormones. And that occurs not only early on in life during the transition of puberty, but also later on in life during the transition of menopause. It can disrupt hormones of all types. In fact, many environmental toxins are known as endocrine disruptors. They disrupt the hormone system. Progesterone, estrogen, testosterone, cortisol, thyroid, growth hormone. We know that they impact negatively the endocrine system and the hormone system. So I look at their exposures. I look at if there's any way that we can perhaps encourage the body's innate capability of eliminating those exposures to the best of our ability. And also the mind-body relationship, because it is clear that stress or the inability to handle stress, poor sleep, our worldview or our outlook upon menopause, all of these can affect our experience of menopause in a physical way. So I always want to make sure that the women feel like they have the tools and techniques to manage and mitigate the effects of stress on the body, be they through relationships or work or finances. There are a lot of stresses that we're all exposed to, and making sure that we all have tools and techniques to help mitigate the physical effects of those stresses are quite important. So the next rung on the ladder are supplements. So I look specifically at the woman's needs and symptoms that she may be experiencing, and I might prescribe a supplement or two to make sure that her hormone levels are being supported, that the metabolites from those hormones are being shunted to a positive pathway in in the metabolics of the body that are protective, both short-term and long-term. And of course, looking at any kind of deficiencies. And common deficiencies of the perimenopausal transition include vitamin D, folic acid, vitamin B12, and there are a group of supplements that are very concentrated extracts from, they're typically cruciferous vegetables. So here we're talking about like brassica foods, broccoli and cauliflower, kale, cabbage, but they're very, very concentrated extracts from those foods called DIM and indole 3-carbinol to help metabolize estrogens and progesterones in the body to promote a healthier form or metabolite of those hormones in the body. And there are certainly supplements that can be symptomatic relief, be they for anxiety or irritability or sleep or hot flashes during the transition. The next rung on the ladder would be bioidentical hormone replacement. And oftentimes that is every bit sufficient for treating those hormone imbalances. And again, I look at the full symphony. I look at estrogens and progesterone and testosterone and cortisol, thyroid, growth hormone to see what deficiencies could be present, and I address them at physiological doses. This is not about replacing it to the point where you were 20 or 25 years old. These are just replacing it to the point where you're 45 or you're 50. And just a little bump in some of those hormones can make a dramatic difference in individuals. And again, the form or the route of administration can differ from one patient to the next, and that depends upon the patient's experience, if it's oral or topical, a patch. They even have inserts where they take a little pellet of estrogen or progesterone or testosterone and insert it into the skin to release a known amount of estrogen into the system each and every day. And then that final rung on the ladder would be synthetic hormones. And I use that as the final rung because we know that they're quite powerful, but because they're quite powerful, they can have effects that are unwanted and that can cause not only short-term side effects today and tomorrow, but they can actually increase your risk for cardiovascular disease and osteoporosis and dementia, which are problems that tend to develop post-menopausally. But every wise woman will begin thinking of those post-menopausal symptoms in their 40s because more benefit is found through implementing strategies earlier rather than later.
Mm-hmm. And by implementing strategies, I want to just highlight the fact that your initial rungs are things that we take control of every day and we own, right? Our nutrition, our movement, the way we sleep, the way we manage or have or change our perspectives on stress. All of those things feed the picture and feed the presentation and the challenge. And from that point, so alcohol, the use of drugs, all of those things factor into this picture early on. We own that, we control that. Um, it's not unusual that when women change their diet, they see pretty drastic differences in their symptomology, right? So if we own this beginning part, we can work in concert with our practitioners so that we can find the ideal personalized experience for us that makes the most sense when it comes to those later rungs of maybe supplementation, especially bioidentical, and at the most working with some hormones that are really significant players but require a lot of oversight.
Absolutely, I couldn't agree more. We have control as individuals over more than we think that we do. And if you think of a common doctor experience, and I'm a doctor occasionally, although I try not to be this stereotype, occasionally I'm guilty of this. If you think of a common doctor's experience, you go to the doctor's office and you wait. And you tell them about your symptoms and maybe have 5 or 7 minutes to describe your entire life and try to condense it into 5 or 7 minutes. And then they say, oh, well, that sounds good. I'm going to give you a medication. Let's just wait and see what happens. That's not the kind of practice that I utilize. It's not about waiting. It's about having passion on your own health, understanding that you have a great amount of control over your health in simple choices through diet, through nutrition, through exercise and movement, through this mind-body relationship that I related to earlier. You have a tremendous amount of control and a tremendous capacity to truly change the trajectory of how you age and how you feel, not just today, but in the future, in the long run. And for me, it's about establishing a therapeutic relationship between patient and provider. Find someone that you trust. Find someone that takes the time to sit down and understand where you are, what your goals are as an individual, and try to achieve them. And it should be a comprehensive approach, not just something where you come into a provider's office, you're prescribed something, and they tell you see you in 6 or 12 months. It really does take an effort, both on the part of the provider and the patient, to come up with effective strategies long term.
I love that. Gosh, and that embodies what this podcast is all about, right? It's evolving ageless. It's not a complete shift of everything overnight. It's evolving and understanding what you actually control. And it's so much more than perhaps what you were led to believe or what opinions you formulated through life. We have the power to override our genetic expression. Our genes are what we're born with, but how they express themselves deal with how we live every day. And so I love this. This has been so valuable and so helpful for anyone in the ages of 40 or above to understand what they're looking for, what they control, and looking forward to when they stand in their own power, right? They can start
Mhm.
doing it sooner.
Absolutely. Absolutely.
Dr. Shelton, it's been wonderful having you on today. Thank you. Thank you so much. If you go to evolvingageless.com, in the show notes, we have everything we discussed today and any links that Dr. Shelton is sharing, the 5 pillars of health and things like that. Thank you again. It's been wonderful.
My pleasure, Michelle. It's always my pleasure to help out, educate, and hopefully inspire as many women as I can.
I love it. So for now, until next week, keep on living ageless. We'll see you then. Bye now.